Can you guys hear me? The ones that are virtual? Emily?
Yes, thank you.
We can hear you back. It's just a little low.
And can you hear us now?
Yeah, we can hear you. It's just lots of
Okay, good,
background
awesome,
noise.
thank you. Okay, now I have to figure out how to do it. Yeah, how are you? I did the exam as well, and I just remember how to get do you want to? I'm very happy. Oh, that's all. Okay. You're fine. Everyone is fine. Okay. I'm good. I can freak out at you and go and harass you. Wait, we're recording, Sarah. Oh, sorry. That is awesome. Okay. Oh, okay, wait, I'll give you guys a minute to look at that. Do you want to grab your exam? Okay. Hi everyone. Steve, fun time with you. All right. Presentations. 39 examiners. Oh, a lot of people. Over 5 sessions and 7 standardizations. The standardizations for paid, everybody else just does it. Kindness of them. Oh hell yeah. We got those arranged. I know. All right, so all the programs do the same stations. We all contribute some of them. You know them there. Okay, so here's the deal. I kind of mixed them up by accident a little bit. So, look somewhere else. Sorry. So I was trying to. There's a whole stack. I swear you were in here because I included you stuff. Okay. So technically you're supposed to be examined at the level of like a pediatrician who's just graduated. Now people are rather nice about it, so that's why, yeah. But at the same time, be very kind to yourself if you see that your marks are like, I didn't do great, but that's okay because maybe some of the examiners were really following this rule. Okay. Now, I will say that our OSCE is not necessarily moving with the time in that it is see it as a assessment of your knowledge and a little bit less as prep for the real thing. Because, as you will hear from 4th years who's just written theirs, it's a bit different. Now, for the 4th years this year, we tried to do a bit of assessment to kind of get them a bit more ready for what the real thing is. It's not like crazy different, but it's a little bit different. So, I think the goal should be for like 3rd and 4th years to just have other set sessions or just a little before the real thing. This is actually a little bit more what it looks like. Ultimately, it's just testing the same thing. Wonderful grade. Okay? And parts. Okay. So you guys always want numbers, so I give you numbers. We're going to go through things. Basically, you just need to see at the bottom if you get better with time. Yay. No one's impressed. Okay. Okay, so first station, seizures. You guys know seizures go well, right? Okay. Remember, a lot of these stations are based on CPS statements. This one is one we see every day. Okay, almost. I don't have much to say other than please know how to manage your epilepsy. This one was kind of fun for the people who did it over the phone. Right? Over the phone. It's just a different scenario supposed to make you feel a little bit more on the edge. We'll say. When you finish with that in silence reading on the phone. Right? Reading off it on the phone. It's also to get like no feedback from the person in front of you, who's not in front of you. Okay, I just kind of added the stuff that really just the highlights, which is always ABC and always put on oxygen, even if they're setting okay, because at some point they're not, and always making sure your patient's on a monitor. Work of, ABC, it's your acute care. Making sure you get a glucose. Don't assume you have an IV, okay? And if you don't have one, please ask for one. Some folks kind of forgot about just getting a weight for this patient, and then really they just wanted you to go through your algorithm of how you would treat, okay? And they gave you a scenario where like the child was still seizing, so you had to give a bit more. Then they wanted you to move on to your next options, and we're pretty open as to what that could be. And they wanted you, so usually in those acute care ones, they do want you to kind of plan ahead, so you can say things like, if this child continues to seize, and I feel like their airway is compromised, I would proceed towards intubation. Even if you don't get to it, you just tell them what you'd want to do. Okay. Now, they did then, the child did stop seizing, they wanted you to get a bit more history on things. Remember, for seizures or any type of event that we don't totally understand, you want to before, how's the child doing before, during, and after they're in front of you. Okay, so kind of see it like that. Physical exam, they really wanted you to focus on like high yield stuff, which is like meningitis. And they also wanted you to make sure you kind of said like I would reassess, I would ask for another set of vitals, and so on. Your differential, this kid had a otitis, so they were leaning towards atypical febrile seizure, but also meningitis had to be on their differential. All right. Any questions about seizures? Honestly, you guys know this. If there's anything, I don't know. Urban complex care. All right. You're a community pediatrician and you're meeting Lisa, who is medically complex. Has a VP shunt energy tube, and you're going to try to help navigate more of the outpatient community strategies, and especially around school. And so I just kind of wrote down the things that people tended to forget. And so that is why what I have here. So in these situations, always asking like, what are the parents' concerns? Some parents have a lot of concerns about kids going to school, and some have very few. There's in between. Okay. So what is their true concern? For these stations, it's like development. You need a bit of a development history. Actually, you need a full development history. You need to know where this child is at, because you don't, it could be a child with a VP shunt or a G2 who's totally mobile and verbal to the other extreme, right? So you need to know a little bit where they're at and what were they before. So you're meeting them for the first time, so it's always helpful to say like, and who follows you, who has been following you, do you have a subspecialty PT, a specific hospital, who's involved with you before, and sometimes you just need to go like head to toe. Who's your neurosurgeon, who's your neurologist, because people forget, especially as the kids get older, who's been involved in their care. And previous management. Obviously, you need medication history, just because some of these complex children are on a whole slew of medications. And sometimes in the community, people don't realize that some of these could interact with each other, right? They don't have like pharmacists like ours who's like looking at everything, or things get added slowly. So getting a detailed history. Feeding, you always want to know what, how, where, how much, what kind of equipment they're using, and anything that feels you're missing and could be helpful for them. Don't take pictures with my OSCE. Okay, you can text, just don't take pictures. All right, and who are the other allied services that they're using? Are they seeing OT, PT? Would they like to? Are they disappointed or not? What's the school situation like? What can be done there? And then they also wanted to explore a little bit how they communicate, and always, 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 how are the parents coping, or the family? Okay. What are the supports, and what's the child doing for fun, right? Like, it's always nice to, in these kind of situations, we're like talking about all the things that their child cannot do, to kind of then focus on like, what can they do? Like, what are the fun things that they like doing? Even if it's very little, it's always like kind of, lift everybody back up. Okay, what other types of evaluations have been done? And then it was like, explain the role. So just trying to see a little bit what has been put in place before, what could be put in place, what would they like to have in the school? Because the next question is, how do you help advocate to support? So community pediatricians will often write letters to school, communicate with schools, just to explain what the needs are, ensure those are met. As a community pediatrician, you're also trying to empower families to do that themselves, so that they have a good relationship with the school, and if they see there's any concerns, that those are brought up early. Okay. So in this one, they wanted you to like offer to refer to any subspecialist or offer to refer to like OT or PT, and write prescription for medical equipment that they might need that they might not have currently. If you know resources of how they can get more resources, great, share those. And then complete any prescriptions that they might be missing. It is okay in these situations, if you don't know, to say, I would try to find more information for the family around specific resources for cerebral palsy. I don't know these right now, and I would then reach out to the family and share that information. So it's okay to say that because you know there's stuff out there, you just don't know the specifics. Okay? Question? No. Neck. Okay. This was baby with a neck. I again wrote down the things that kind of people that were high yield from the marking scheme. So here they wanted you to explain how you would kind of assess this patient and what you'd be specifically looking for, right? So you can say I would have a look generally at the patient, but specifically in this situation, I am looking for on my vitals any temperature instability or low temperature or fever. I'm looking for, right? So you're demonstrating that you know that this child is in distress or that you're looking for a child that's in distress. Okay, I don't remember the specific scenarios, like they're in front of you or not, but that is generally what they want you to look at. Then on your physical exam, same thing, you're demonstrating that you know what neck potentially could look like. You can also say neck could have a fully benign exam, and still have neck, right? So when you say specifically, I'm looking for abdominal distension, visible bowel loops, some discoloration, and so on. Cardiac exam, again. So then they wanted you to investigate. So what are your high yield investigations you want to do? And then they just wanted also some imaging. They asked for a differential for this baby. These are all the options that we had, which are all totally fair, and it should all kind of always be on your differential for babies not tolerating heat. Then you just have to go through management of your next baby. As you do more and more and more picking, this comes very easily. And so things people kind of forgot, transferring because they're not actually in the right location. TPN, obviously that's like you say, like in aim to start TPN, because you're not going to start TPN like this. And so on. So again, this is a bit of acute care. So if you feel like this patient could become unstable, say that. I'm worried this patient could become unstable on transport. Based on my location or my resources, I feel it could be safer to intubate. But you could say, you know, as an option, okay? And then you're transferring. Okay. Neck complications. Sepsis of the progressive, perforation, increased risk of recurrence. They didn't say like short term or long term. You could have it there, either one. Okay. Where did this come from? I found this and I thought it was good. How to use abdominal X-ray in preterm infants suspected of developing necrotizing if you guys need an extra resource. The X-ray findings. Now, for some weird reason, I couldn't actually like cut and paste our own X-ray. This is very close to what it looks like. So, can you see my? This does not look good. This looks like bubble, right? Can you guys see it? Yeah. Okay. All right. This does not look good. This is there in the liver. It should not be there. Okay. So combination. I mean, this one is terrible. This one's not great either. But here's your. Okay. All right. And if you're not sure and you're here, you can call your kind radiologist. Any questions about that? No. STI. Alrighty. There are two statements that could be helpful for this scenario from the CPS. Please read them. So this was our 16-year-old who needed some counseling on STI testing and contraception. They really packed it all in for you guys. History. Now, I think you guys are getting better at confidentiality favors not being forgotten. Yes, you have. And I will continue until the end of today. Continue. And sorry, I wrote menstrual history. Sorry, that's the other part. Okay. Things not to forget. Any contraindications for this patient to contraception. And the things that were in this one, which we need to always kind of add now to our health history, is any sexual assault, any exploitative sex, trade, like are they being trafficked? Like, and you would be surprised how unfortunately common and it does happen. And children and teenagers might not even realize it's actually happening. And that's the scary part. So it's getting a bit more information of who they're having sex with, okay, and for what reason. So these just expect that these adolescent patients are getting more and more. We need more and more details as if they're doing more and more things. Here they wanted also to talk about emergency contraception, advice, recommend STI testing. It was a lot. Really what they were getting at in the last part though was just to make sure you guys understood the age of consent because it gets pretty complicated. Okay. In Canada for sexual activity, the age of consent is 16 years old. Exceptions. Okay. When there's a relationship of trust, authority, dependency, or exploitative relationship, the age of consent is 18. Do you guys all understand that? Yes. Next part, the close in age exception, because there are, obviously we always run into this. So 14 or 15 can consent to sexual activity if their partner is less than 5 years older and in no relationship of authority. Okay. And here a 12 or 13 can consent to sexual activity if their partner is less than 2 years older. So a 12-year-old can have sex with a 14-year-old. Tell me. I think it is including, like in my mind, I think it's including the partner. I know.
15 and 11 months.
I know. I think it is when it is all based on the history and what is this relationship, really, right? They just don't want people to be exploited. But it has some wishy-washy next to it. Okay. Then they wanted you to recommend list 2 recommendations if you like for a patient to start Eagle Rivera, so the shot. And here they just wanted you to be aware of the side effects. Okay. Medical error. The CPSO has a nice link for you on advice on disclosure. Yeah, advice to profession, disclosure of harm. This was a 4-month-old who had not received antibiotics for their Kylo. Now they added a twist in that there was a family history of infant death. So to explain why the family was particularly upset. And we had a wonderful standardization who really took this role on. So what they wanted was for you to disclose the incident and you need to apologize. If you did not apologize, and you can say, I am sorry that this happened, right? You're not apologizing that you did something wrong. You are sorry this happened. It shouldn't have happened. You needed to apologize. If you didn't apologize, the scenario took you in a slightly different turn. The SP had a different scenario, like speech versus if you apologize. Okay? The not apologizing did not go well. Okay? Always remember to apologize. Same thing you would do in real life. Respond to their concerns and their questions, right? Truly express your concern, right? Like you're being empathetic. You realize this very much so. While using honest, sincere, and empathetic communication. So there's not much to this one. It was really like how your approach. So the marks are not based on like a bunch of PPs. They never are. They're based on how the approach was and whether you apologize or not. Okay? Questions about it. This is also one where you can say like, we will ensure that we fill out as SRS. We will have further meetings. We will do an analysis of the events that occurred, and we will communicate with you the changes that we plan to make to ensure that this doesn't happen again. All right, we're good? The written station. Yeah. They make them really hard, okay? So we'll go through them. It's all good. I was a very kind marker, I think. So it's okay. I expanded the list a little bit of what else we could do. This is a type of eczema. Pityriasis alba. It does not show up on a wet lamp, and I'll show you what it does. Really, how you decrease the appearance is with sunscreen, moisturizer. You can use a little bit of steroid. It does go away. It looks worse in the summer, not because it is worse in the summer. It's just the skin around it tans a bit more, and so that's why it looks worse. Okay. It does go away on its own. Yay. Okay. We've seen a few of these. All right. Molluscum. All right. Now, hopefully the pictures are okay. It can persist, but it will eventually get better as your immune system improves. Now, somehow only 2 people knew what the virus was. It is all by contact, or if you're scratching, or kids are scratching and then they scratch themselves somewhere else, so they can actually spread this onto themselves. And some of the complications, so that you can get like a full reaction to it. I accepted like cellulitis, I accepted abscess, I accepted like anything that was like near it. Pretty much. That was super kind. So, but I'm sure you guys, if it had been like on a real patient in front of you, you'll figure it out. Okay. This is what we see all the time. Now, I'm sorry. The books that wrote Mongolian spot, I did not accept it because it's not a term we want to use anymore. Okay. But I gave you those marks for the other stuff. So, because most of the time the rest of it was totally fine. It does go away with time. Important to really document the location, the number, the size, right? You guys agreed on that question. And then name a disease with persistent and extensive lesions. Again, I accepted a lot of things, right? There's a lot of things that those are very too broad. Okay? Okay. Vitiligo. This one does show up in a Wit's lamp. And the most common autoimmune condition is some type of thyroid disease, like that. It's just Hashimoto's. Now, there's many ways to treat this, okay? So accepted a lot of things. Now, some folks give me some really nice, skincare routine oil that's essential. And I did look into them for this one or the eczema. I didn't really find good evidence, so I did not accept. Did you adjust your own skincare? Because of it? It's oil, oh, I forget what it was. It was vitamin something. It was awesome. No, I did not. Okay, Wit's lamp is ultraviolet light that highlights. Sorry, I can't see. Pigment changes. Okay, so we're gonna see it in fungal infections, apparently bacterial infections, and pigment disorders. Okay. Ooh, porphyria. We need it. So it looks like this. Yep. So this is what it looks like with. Oh, sorry, my picture kind of went. So this is the nose one. You can barely tell, and then with a Wit's lamp, it really does show up. Okay. All right, everyone's favorite. It was neonatal lupus. Who's seen neonatal lupus? You will. I love it. So this is neonatal lupus. I totally understood why people thought it was different. I added so much pictures. It was a tough one. We have just let it go. You will.
I did not lie. I just looked at
Yeah. So for this one, the big thing to remember is that it is all immune. So you do need to do some serology. Usually you know this because but these were just some of the things I wanted you to do. The only thing I remember is congenital heart block. But this is what it looks like. It does get better with time, and supportive care also is totally fine to say. Recurrence, 20%. Okay. Questions about the written?
Well, if I think my answer is on here, can I check the date? You didn't come?
Oh yeah, I don't have my written.
Yeah, I don't either.
Oh no, oh my god. Sorry.
It wasn't good. I don't need to see it.
I'm so sorry.
I wanna know if I didn't, you know, I just love if I didn't know.
Are you sure they're not? Look at the very back. Look at the very back.
No,
Is not.
I did look all the way back before I.
I'm so sorry. I have to check on them. I really thought I had put it. I'm sorry. Okay. Cardiac exam. With Will, our standardized patient. Now, I'm not going to teach you how to do a cardiac exam. I just want you to review and expand and be very specific and remember that you examined from the patient. Basic. Okay, always introduce yourself, wash your hands, refer to the patient by name, explain what you're gonna do, and drape appropriately. Here, do you, yeah, this is what focused cardiac exam should involve. It does involve things that are also a little bit outside of heart rate. You can look at their legs. And they want you to communicate as you're doing the exam, and you can say, and here I am feeling a little, okay? Yeah? Okay. They needed a bit of tweaking, so please take some time tonight to review detailed cardiac exam and practice again so that it is very detailed and looks super smooth. We did accept JVPs for these ones because Will was 11. And you could say that. You could say, I'm going to do a JVP on this patient because he is 11 and he probably has one. Okay? As opposed to looking for a JVP in the clinical. Okay. That is the only slide. Oh no, I did. There we go. So ECGs on an OSCE, we're really going to ask you two things. QT, long QT, and anything else would be weird. It'd be acute care, right? So we tried to make it obvious because we know that in the situation it's stressful and you're trying to count the little red squares, can be challenging. So, and because we usually want you to then manage it, right? So here, I appreciate it wasn't just that ECG. However, this is what it looks like when you blow it up, okay? Can we now see the QT prolongation? All right, so I did the math for you. So your your QT is 0.6 seconds. It's 3 big squares. Okay, each square is 0.2 seconds. And then your RR was 5 big squares. Each big square is 0.2 seconds. So if we do math, your QT, and they made it super simple because you don't have a calculator. And so your RR is 1 second, square root of 1. So 0.6 divided by 1 is a crazy long QT. Okay? You don't if you know anything, 600 is all right. So it's okay. A lot of folks were been told, we're focusing on some other aspects of the ECG. Let's just a quick peek. Think about what are they really going to ask me. If it's not SVP and it's not QT, then you can fill in QT. Then you can do more thorough ECG assessment. But that's me most of the time. Okay. Are we okay with calculating the QT? Now is the time. It's zero judgment at all. Okay? I count the little squares every time. Okay. Superb. Disruptive behavior. This was a tough one. Again, I don't do community piece, so I don't know. I've learned a bunch of stuff. Disruptive behavior disorders are problems with self-control of emotions and behaviors which interfere with a child's ability to function at home and at school. The child violates the rights of others or enters into conflicts with people of authority. So frequent tantrums, angry outbursts and irritability, argumentativeness, defiance, and threatening or aggressive behaviors. And they really like to break stuff and steal and seriously violate rules. Okay, so there's the big ones in that category are your oppositional defiant disorder, your conduct disorder, and your intermittent explosive disorder. So I'm only showing you this because really the history was to try and like get at the, could this child fit into one of these disorders? Is that what's happening? So the oppositional one is really just angry outbursts and blaming others and trying to annoy. And the conduct is they're more actually like trying to hurt people and animals, trying to break stuff, steal stuff. And then the intermittent explosive disorder is really just like big outbursts that it takes them quite a bit of time to come back down. There's also pyromania and kleptomania in this category, but I did not explore that. You can guess what those are. Treatment options. Now, this is what in the station they wanted folks to explore with or to describe with some of the behavioral therapy that's there, a family approach and what kind of family therapies would be available before you kind of talked about treatment options. Okay. And it's always about trying to, give a child some structure and letting them know what some of the consequences are and also giving them strategies to cope with it. This takes a very long time, but that is the general. Okay. For the family, is really trying to increase the structure and to try and anticipate when these behaviors are going to come out. So if you're going to take a child with a oppositional defiant disorder and they're going to be hungry and tired and you're taking them to Walmart, that's a terrible idea, right? There just is too much stimulation. You need to address their needs. Don't put them in a situation that's bound to fail. Okay? And really focus on positive reinforcement, which unfortunately these kids, like a lot of the time, people are really just focusing on the things they're doing poorly, or the things they shouldn't be doing. And so trying to get families to focus on, even if they're really small, you didn't punch your sister in the face today. Yay, right? I said that to my 5-year-old. My 5-year-old, the other day. So I know, it's also just regular kids. But that's like, just trying again to bring a positive light on the situation as a pediatrician. They did want you to talk about referral, but these are some of your other options, and so just for you guys to know, you can use stimulants to kind of help control some of the outbursts. It kind of really depends on the child. Risperidone for aggression. Some SSRIs more for if there's a component of anxiety or depression. And then mood stabilizers, especially in teens, you can use BPA. And then the whole non-stimulant ADHD treatment. So you will probably see some of our kids are being on clonidine, and that is again trying to decrease impulsivity and aggression. So this is, you have options. It's all about what other medications they might be on and what are the side effects and what the family is willing to accept and go with if they're ready. Okay? Asthma. You guys do a lot of asthma. You guys did pretty good on this station. There's obviously asthma CPS statements. And here they also wanted you to kind of do some counseling and do some teaching. So they wanted you to, a general question like, what do you know about asthma? What do you know about your child having asthma? Just to see where you're starting off, and then providing helpful information. Trying to make sure you use short and concise language, small chunks of information, checking that they understand, avoiding large jargon, or if you're going to use jargon, just explaining what it means. And then try to assess a little bit what their feelings are around the treatment options, and what might be some of the barriers, And anytime you are like in a station like this and you're in a clinic, and just say, and I would plan for follow-up. And okay, making sure that you show that you appreciate there's continuity in the care that is going to be required. They wanted to, we'll look at briefly at the PFT. They just wanted you to chat about asthma management. Okay. I added the CHIO website that it has also some extra stuff on. There's an ebook. There's some information on like how to clean your air chamber. There's tons. So if you're like in the station and it was really long one for the amount of time you have, if you're like, I'm going to run out of time, just say, I would like to, please look at our CHIO website for further information. Right here, it still counts. You're still sharing where they can find the right info because you don't have the time. Or you could say, I would bring you back next week. We could do more teaching. Blah, blah, blah. Something. Okay? I just added at the bottom, you have 2 guidelines. They're both a little bit different. Stick to the Canadian ones for now. Things are changing, they're updating. Nothing huge, but some more to come.
There's a lot to go over in the and I know it's a thing like look at the and go through, but then like look at the checklist, there's something that you want to go through and the details.
Yeah, the thing is like, yeah. So you can, the checklist is just like more for the examiners to have something to go on because like they're not all rheumatologists or general physicians. So I say if you have 10 minutes and you need to try and teach this patient or this family the most high yield stuff that's going to keep them at home and not come back to work, I would say. So you do need a good inhaler technique and you need to like quickly tell them what to do if things get worse. The rest you can try to teach, okay? Or teach them. But it is, and it's okay. It's just, again, just practice, right? Like, just practice. If it took you too long, it's probably because you had time to say. It was probably very good. So don't worry about it, okay? All right, PFTs. Did you guys have time to get to the PFTs? Yeah? Okay. They start?
They were like,
Oh,
oh, great. What you did with it. So I spent so much time. I'm on Taylor technique. I was also confused with it. Are you supposed to do that?
I know.
This is
asthma.
I don't know like this. My main
So just to very quickly go through it, you right away you just want to know is it obstructive or restrictive, and you already knew it was asthma, so there's going to be obstruction. And so your FEV1 over FVC is, that's fine. Less than 8.85. You just have to remember some numbers, okay? And then what's your typical cutoff? You wanted to assess severity, and that's just your FEV1, which for her was 68. And you just wanted to make sure there was a bronchodilator response, which there really was, okay, in your FEV1. Okay. You don't need to do more than that, right? Like, oh, you also don't have much more information. Environmental impact of inhalers is should be at top of our mind as well, because we're realizing the huge impact just from the hydrofluorocarbons that are in the inhalers. Okay. So what they wanted you to say, so I'll say it just here. There's like the impact and the ways to decrease that are all related. They wanted you to say like improving the disposal of inhalers, trying to also make sure that you're using the right inhaler, using a controller so that you could prevent the use of frequent ventilating, basically. You're making sure that they're have the right technique so they're not using puffs when really the thing is going in. You want to try to switch to dry powder inhaler because then it doesn't have the carbon, the hydrofluorocarbon. And you want to make sure, like, there's a bunch of pharmacies that will take your inhalers and dispose of them properly. And trying, like, this is bigger stuff, right? Advocating for change in plastic packaging. They're also, there's a push to also have like a counter on your inhalers. They don't all have counters, so then you know how many puffs you're using and how many puffs you have left. And it's just all around this way then you can keep track of it and hopefully decrease your waste overall. Okay? Yes. Constipation. Things people often forgot. Just when did they pass meconium? Review some systemic differential, like, you know, could this be IBD? So ask your IBD questions. Is there something more concerning, like more these symptoms? Could this be infectious? So like a travel history, and then anything neurologic, right? Like that's impacting actually their legs, their mobility, their muscle weakness, that type of thing. So this is what we do every time we take a constipation history. The exam, they did want, developmental history goes back up, sorry. They did want you to comment on gross motor delay or any type of delay. And then on the age of toilet training. Toilet training is actually usually when things start with constipation. It's usually like either toilet training or when they go to school. Those are two very stressful times regarding pooping. And so they want to know, you know, is that when things started? So very important information there. They also wanted you to ask about, like, if it is IBD on your exam, like what, showing that you know what the other physical extra GI signs of the IBD were. And then they did want you to have a look at perianal exam. And you can say, like, with proper, if the parent and the child agrees, I would like to have just a general inspection. And we do, right? We do it every time. And we don't do DRAs every time, depending on what the situation is. We don't assess anal tone every time, again, depending on the situation. So we will have a look, okay? Then the management. Now, we talk about constipation every day. I'm not going to do this to you guys today. Please review all our resources. GI kids, always helpful. And this is, they have a very nice package of information. Again, you can say in a station like this, I will ensure they have proper resources, and here are my many resources. Now, if you guys were at Grand Rounds a few weeks ago, and you saw the constipation talk, it was awesome. If you're gonna watch something, it's on YouTube. It's great. Okay? People were really pumped about it. She does a really nice job. Have a look at it. It's gonna be a very useful hour. It flies by partially to the entertaining topic. Okay? OSCE tips. I like you guys know them, but I'll still, these are in mine, but you guys can have, feel free to share more. Really, you're just trying to show us what you know, okay? And that does mean being super specific, if you can. So in your written description, please be specific. I know you guys know, and it's just like, if you give me what you question,
I think it's all with me to know.
and that's fine. Well, some you don't, some you do. But like, or, okay, to be specific. Same thing for, what else do you know? I think I've said this to you guys a few times now. Try to expand on, like, I would be looking for signs of IBD or physical signs of IBD, such as, give me a look, okay? One of the big tips is whenever you walk in, you should never walk into a station with like blank, like no thought. No. Always saying, what is my differential? Like I need to have some type of differential of what's happening. Okay. And if it's not a differential station, then I need to, what is, like, if I could name the station, what would it be? Adolescent medicine, teen with drug use, like what can I put a name on it? And is that, because that might actually really be helpful for you to change your approach. Okay. So do your best to go in with an idea. If you have zero clue, that is totally fine because it's a learning exercise, right? Just keep in mind what the station is going to be so that you can go home later and learn about it. But at that point, you can write, like, I'm just going to do like my very general history and hope for that. Okay. People did fine with reading the prompts this time. I don't think things were too convoluted. One was like really long. That's okay. It ended up being next, right? You guys, you needed that information. But you're right. Like we all know they were a bit too long. Try to have a script for the ones you know. Adolescent medicine. Keep your, you know, these ones, right? Work on them, practice them so that they become very easy for you to do and low stress off these stations. Okay. Okay. Remember, this is just practice. We look at it in the big picture of who you are as a learner. We're never like, they did terrible in this one OSCE, therefore. Okay, it's never like that. Okay? Questions? Yeah, so we did it with we did it this year. We had Regan come in and talk, and we talked a little bit more about what it looks like or feels like. And I'm gonna meet with some of the fourth years to try and like put it together. But yeah, it's important to ask as you get closer, just to have a bit more. It's just they interrupt you a lot more. They make you move to the next station. Like you don't get a chance to expand too much. It's a much. They're trying to get you to take you. And so that's why they're like, okay, now I'm giving you this result. Interpret what's a differential. Okay, what and even things at moments they might ask you, like if you're starting to get a history, they'll be like, why are you asking that question? Okay, and you have to explain why you're asking that question, type of thing. Okay. All right. Now I will say for now, this was my last talk to you with you guys. I'm not leaving. I'm just I've done OSCE for many years. I'll be around. Maybe I'll do it later another time. It's all good. Thank you so much, guys. It's been awesome. And I hope it's been helpful over time. Okay?
Thank you.
I have no idea. No.
Sarah was just so proud.
Thank you. All right. I'm gonna bye everybody who's